I welcome you all to the academic presentations of family medicine registrars. Today's presenter is Dr. Fatima Fainaz. She studied at Maliyadeva Model School and Holy Family Balika at Kurunegala, and got her university education at University of Sri Jayawardhanapura. She did her internship at Teaching Hospital Kurunegala and did the post-intern appointments at Maho and then Kurunegala as an anesthetist. And she did DFM in 2015 and joined our batch in 2021 as a family medicine registrar. And I'm glad to invite Dr. Fainaz to continue her presentation on acute hemiplegia.
Thank you very much, Dr. Prabhat, for your kind words of introduction. Good evening, my dear teachers and my dear friends. Today, I'm going to talk about one of my patients who has presented with acute hemiplegia. This is how we present. It was on 2022, 11th of 22nd, at 12 p.m. It was in DCETU at TNH Candy. The patient, Mr. P, 62-year-old, was taken to ETU by his neighbor due to sudden onset left-sided weakness since 11 a.m. on that day. Now, what are the thoughts comes to your mind? What could be the reasons for his acute onset weakness?
Ischemic stroke comes to mind.
Oh, yeah. That's right, Shane. What else?
Ischemic or hemorrhagic stroke both can be.
Yes.
And there are...
this can be even a transit ischemic.
Yeah, Dr. Supun, yeah, it could be a possibility.
And rare causes could be like hypoglycemia.
Yeah, very good. Yeah.
Hyponatremia. And sometimes rarely migraine. There's a hemiplegic migraine also, but not today.
Yeah.
Those are the things which comes to my mind.
Right.
And also some patient with cancers with secondary deposit or mets in the brain.
Yes.
Is that also a rare possibility?
Yeah, it could be. And what else?
Somatoform disorder conversion.
Yeah, very good. As family physician, we have to have a very broad mind to identify the illness of the hidden illnesses in the patients. So let's see, these are the possibilities as you all told. It's acute stroke, hemiplegic migraine, could be metabolic causes, infectious causes, and acute disseminated encephalomyelitis, even though it is rare, I have mentioned as a cause, and there are some possibilities, cerebrovenous thrombosis, and epilepsy could be present with Todd's palsy. And there, as one of you know, that psychiatric disease, depression, or somatization. Yeah, keep all this in my mind. I search for his presenting complaint. Sorry, what are the things you asked in the history to exclude the causes and arrive at the diagnosis?
Well, stroke, of course, sudden onset face, arm, leg weakness.
Very good.
And also we can include the, symptoms of posterior circulation.
Very good.
The dizziness and blurred vision, things like that.
Yeah.
So then that's that. The migraine, of course, the headache and aura. There's a history with photophobia, phonophobia.
Yeah.
And hypoglycemia, well, then there can be palpitations, sweating, features like that, supportive features.
Yeah.
Electrolyte imbalances may be muscle weakness, things like that, but not specific. Maybe
But still, patient can present with weakness.
Yes. Infectious causes, fever has to be the IBDs. That.
Yeah.
Epilepsy, then there should be a weakness.
Yeah.
And then
altered consciousness or fecal incontinence.
With another
bowel bladder incontinence with tongue bite like thing.
Yeah.
Or epilepsy.
Yeah. Right. These I have asked from the patient. It was a left side weakness developed when he was sitting on a chair while reading a newspaper, which fell down from his grip. First weakness started in upper limb, where it spread to lower limb in succession within 5 minutes. He couldn't feel any sensation from the affected side or felt no pain over it. He could not move his left limb anymore. He shouted to his neighbor for seeking help. He has had a headache in the morning around 9 a.m., which responded to paracetamol, but no neck pain, no visual disturbance along with it. He had no any diarrhea or vomiting or urine or fecal incontinence. And as Shane said, there were no fever, and he had no features of chest pain or palpitation. He denies anorexia or weight loss, no history of trauma within last 3 months. He didn't have bleeding from any orifices. He didn't have any involuntary movement or loss of awareness suggesting epilepsy. He did not have any cortical symptoms such as alexia, apraxia, or agnosia. He didn't have swallowing difficulty or mouth deviation. He denies any visual or memory impairments. And now that's total history. And at the same time, I would like to say he didn't contract the history of COVID infection because he took over 3 doses of COVID vaccine. So in past medical history, these are the things I could find. He met with similar event in same manner 2 years ago and was treated at NH Candy and fully recovered, but not being followed up afterwards. No records available. And he didn't have diabetes, hypertension, ischemic heart disease, or any psychiatric illnesses. And he did not done any lipid profile, fasting blood sugar, or blood pressure measurement during last 1 year. He did not have any cancers in his body. He did not have epilepsy in the past. No recent viral bacterial infection encountered by him. No history of rheumatic carditis. He gets on and off frontal headache, which respond to paracetamol and do not limit his activity of daily living. He used to get 4 headache days per month. In past surgical history, he did not undergo any surgeries within last 1 year. Family history, his father died of MI at his age of 70. The father too got similar type of headache, which he did not, he got relief by applying oils in head, but he did not get weakness along with the headache, because I asked, because one of our DD is hemiplegic migraine. So this hemiplegic migraine, usually it's familiar. Usually one can get, if one can get first degree or second degree relative might get this. That's why I particularly asked about it. Then he didn't have any allergies to foods or drugs. He has not taken any drugs such as antiplatelets or anticoagulants. Smoking and alcohol history. He was an ex-smoker, stopped 10 years back. In past 4 to 6 cigarettes per day for nearly 13 years. And luckily he is a teetotaler. In dietary history and exercise, he used to cook for him, but some days he buys his foods from outside. According to him, he is not taking a balanced diet with all nutrients, and he is not engaged in regular physical activities. In social history, what are the things specifically we have to ask? Because he is now comes with hemiplegia, with a long-term debilitating illness. What are the things we have to ask specifically in family history, social history?
We have to ascertain who are the family members.
Yeah.
And the financial status.
Yeah, very good.
And perhaps what sort of house or place they are living in.
Yeah.
You know, whether there's stairs involved, and
very good.
how they travel and move about, and whether it's on a mountain
further than this,
like that.
Falls, no? Yeah. This is what I gathered from the family social history. He is a father of 2 children, age 34 and 30. Children and wife live separately for last 10 years due to some family disputes. He lives in a rented house. His wife and children do not visit him even for his last hospital admission. He strongly believes in his religion. He denies any form of sexual promiscuity. He is an astrologer by his profession. Many people from various parts of the island used to visit him for future advices. His mood was low but preserved appetite, but lack of sleep and lack of energy was there, for which he attributed to his workload at Jyotish office. He did not have hobby. He denies any suicidal thoughts. This is his concern. And his idea was he thinks this has happened due to his karma. He does not think that his family would come to see him, and he now expects to get a speed recovery and go back to his ordinary work as an astrologer. Now, what are the diagnoses? Now, anyway, I have put. Now, with the history, we can reduce some DBs. Now the differentials are these: acute stroke, hemiplegic migraine, psychiatric disease, or could be functional, or metabolic causes. We have to, if we want to exclude these metabolic causes, even the history is not suggesting, we have to look for the electrolytes. Now, these are the examination findings I got. He was the average big person, afebrile, not pale, but not plethoric, not dyspneic, no rashes, no neck stiffness suggestive of meningitis or encephalitis, and he has no features of lymphadenopathy in neck, axillae, or inguinal area, or he didn't have any thyromegaly. Testing for back tenderness to percuss was negative to rule out the vertebral inflammation, vertebral tumors, and epidural abscesses. And he didn't have any ankle edema. Now, what are the things in the CVS examination we have to particularly look for?
Well, the pulse and blood pressure, and basically the rhythm
Yeah.
is important. And heart murmurs also, cardiovascular system wise.
Yeah.
Yeah, that is the CVS examination.
Okay. Right. His BP was 132/89, pulse rate 102 beats per minute. It was regular. Cardiac apex not displaced, dual rhythm, no murmurs, no carotid fluids were found. And respiratory examination was perfectly normal. In the abdomen, there was preserved abdominal reflexes, superficial abdominal reflexes, and no palpable masses or enlarged bladder. You can get enlarged bladder during spinal cord transaction. So it was not there. Digital rectal examination was normal, or anal tone, and prostate also normal. We have to look for the prostate in this age, so it was normal. Now with the acute hemiplegia, CVS is the mainstay of examination. He was conscious and rational. GC was 15. He oriented for time, place, and persons, and cranial nerves were normal. And he had no asymmetry of the body or no surgical or traumatic scars indicative of spinal cord damage. These are the findings of the motor system of upper and lower limbs. Usually, if a patient comes with the weakness, tone and the power is reduced, his left limb power is reduced and tone also reduced, but the reflexes were normal. In lower limb also power and tone reduced, but unusually we couldn't get the plant extensor planters, so it was equivocal. Sensory system, left side, all the sensation were lost, including pain, temperature, touch, vibration, position sense, while all the sensations were preserved over the opposite side and the trunk. Coordination was normal, which exclude the cerebellar lesions. And this is the summary. 62-year-old man presented to hospital due to acute onset left side upper and lower limb weakness for 1 hour. He had only motor and sensory impairment with preserved higher functions of the brain, including bulbar and cortical functions. He had seen the episode 2 years ago, which was fully recovered by treatment at hospital, and then he was not being followed up. He used to get headache, but not preceded by motor weakness. He lives alone in a rented house without a single companion and showed features of moderate depression. On examination, all systems were normal except altered neurology. It revealed flaccid left arm and leg with dense anesthesia in affected limbs. All tendon and muscle reflexes were normal, and Babinski signs were absent. Now, the patient came with the weakness. To do a voluntary movement, this is the pathway you have to complete. If you have a intention to do a thing, that should be come from the cerebral motor cortex, and then should transmit to upper motor neuron, and then link to the lower motor neuron, and to the muscle contraction via neuromuscular junction. So the weakness could be area in this pathway. So dysfunction of upper motor neuron lesion could be found in the corticospinal or corticobulbar areas, and you can have low motor neuron lesions due to peripheral polyneuropathy, so anterior horn cells. At the same time, you can have the muscle weakness due to myopathy. So we have to keep them in mind and examine in order to get a proper diagnosis. This is for your knowledge. In upper motor neuron dysfunction, you can have increased motor, muscle tone, muscle stretch reflexes, and extensor plantar reflex. But upper motor neuron dysfunction, tone and reflexes can be reduced in several locations like spinal cord transaction and damages to the motor cortex in the precentral gyrus. In lower motor neuron dysfunction, usually you will have the disrupted reflex arc showing hyporeflexia, reduced muscle tone and fasciculation. And you can get, if it's long term, you can have muscle atrophy as well. In peripheral polyneuropathy, most noticeable in longest nerves, that is, weakness is more prominent in distal limb than proximal. That is, you can have the weakness more in legs than arms. And you can have reduced muscle tone and reflexes in polyneuropathy. When there is a neuromuscular junction dysfunction, you can have fluctuating weakness, which worsen with activity and lessen with rest, which will be there in myasthenia gravis. And diffuse muscle dysfunction in myopathies, you can have the features most noticeable in large muscle groups, that is proximal muscle. This patient has had only motor weakness in upper and lower limb without preserved sensation in the face. But it's little odd to have, but still he has dense sensory loss. If the patient is having a sensory loss with motor weakness, there should be a large area, and you see the large area should be involved to occur. So we have to get a quick diagnosis to intervene for a proper treatment. Other things, some of our friends told that this could be due to hemiplegic migraine. Actually, my patient had headache, but it was not followed by motor weakness. Usually, in hemiplegic migraine, you will have some other features like motor as well as visual, sensory, and speech symptoms, which was not there in my patient. So, hemiplegic migraine can be excluded. If now we are thinking of functional weakness or metabolic derangement or acute ischemic stroke. If we are thinking of acute ischemic stroke, we have to have a neuroimaging, that is non-contrast CT, and we have to look for dense MCA sign, because if there is an infarction, the radiological features will appear late, but the only thing you can see is this dense MCA sign. So So we have to have a neuroimaging on our patient in order to rule out our diagnosis. So these are the investigations of my patient. Actually, we have in ETU setup, if we are going to plan to do thrombolysis, the CT brain and on fasting blood sugar is enough. Because we can't be wait till the other investigations come. If the patient's history is suggesting that he is not having the contraindication for thrombolysis, we can straight away, if the patient is fitting to the criteria, so you can straight away go for the thrombolysis. But our patient, even though all the investigations were normal, CT brain also only the finding was bilateral maxillary sinusitis. See, his features were very much suggestive of ischemic stroke because he has had a very flaccid upper and lower limb and reduced muscle tone and the power, and he has similar past history. So here we can exclude the other thing and still in my differential diagnosis, acute ischemic stroke and psychiatric disease. Even though he has, according to my history, he has moderate depression, we have to keep that in our mind. Anyway, our neurological team diagnosed him as acute ischemic stroke and assessed for the eligibility of thrombolysis. And these are the exclusion criteria for thrombolysis. None of them have fitted to his history. So he was thrombolized after assessing his this NIHS stroke scale. Usually, now we are looking for especially 11 things. It's level of consciousness, orientation, commands, best gaze, visual fields, facial palsy, motor functions, limb ataxia and sensation, best language, speech, and extinction and extinction. According to this scale, the score he got is 8 by 30. So if the patient is less than more than 5 and less than 25, the patient is eligible for thrombolysis. But if the patient has had a score more than 25, it's not indicated for thrombolysis because it's a large area and there is a high chance of bleeding. So luckily our patient was fitted to the NIHS stroke scale and ultimately we thrombolized. We thrombolized with tissue plus recombinant tissue plasminogen activator. It's usually the dose is 0.9 milligram per kg. And he was observed for bleeding in HDU, and vital parameters were observed for 15 minutes for the first 2 hours, and then 30 minutes for next 6 hours, and every hour until 24 hours after initiation of thrombolysis. And then the patient now he's in the ward. Next day ward round, we are reassessed. The patient was reassessed according to the modified ranking scale. Now the score given to him was 4. He was has had moderately severe disability. He unable to walk without assistance and unable to attend to his own bodily needs without assistance. But what could be the diagnosis now? The reassessment by the neurological team, the clinical picture was not changed. RNS scale is 4. Now, still there is a possibility of having acute stroke because this is the post-thrombolysis functional assessment done by Dr. Dissociative at National Hospital NHS. Only 51% will have the independency after the thrombolysis. Rest will dependent, and the rest of them will have little weakness. So our patient can be fitted to this category. So we'll see what's going on. As he had features of depression, we had some suspicion in our mind because some features are not 100% explained by the acute stroke. So we did this Hoover sign. It is to find out the functional cause of motor weakness. This is how it is done. Ask the patient to flex his weak limb at the hip. In the normal people and in patients with organic hemiparesis, you will feel downward pressure under the opposite heel. If you put your palm under the opposite heel, you can feel a downward pressure. But if you feel nothing, it suggests a functional weakness. That is, the effort is not transmitted to either legs. Unfortunately, in our patient, it was positive. Based off our resources. Now we have you thrombolyze with the very expensive drug. Anyway, don't know where the fault. Actually, we didn't have took a good history. And that's why we could diagnosis depression. So we did a psychiatric referral and diagnosed him to having dissociative motor weakness and treated for severe depression. So this is the prevalence of depression in Sri Lanka. Actually, patient is severely impaired much more seriously in terms of their functions and work or in their relationship with the other people. They are much more withdrawn, and it is the disorder with preserved mental state. So we have to have a very broad mind and very broad eyes to diagnose this patient with depression as family physicians. This is the study done by Dr. Miyuru Chandra Das, which was published in August 2022. Overall prevalence of depression was 20.3, and highest prevalence among young it was 41, and in adult it was 8.7. In older patients it's 18.4, and maternal in population it is 19.7. So most of them are not detected and not having treatment. So as primary care physician, it's our responsibility to identify this percentage and treat accordingly. So conclusion of this study was 1/5 of our population was detected to have depression. So depression in elderly, it has bizarre features. It may be misdiagnosed as dementia, psychosis, or like in our patient, stroke. And depression often missed in elderly because it is atypical and less expressive. Therefore, a detailed social history is mandated. This is how you will diagnose the major depression according to DSM-5 criteria. But after the examination, re-evaluation of the patient, we found that the patient has loss of interest and insomnia, loss of energy and worthlessness, and he was tearful when we asked the history. We dig into the history, but we couldn't find it in the emergency department. So this is how the conversion disorder, that is functional neurological symptoms, are diagnosed according to DSM-5 criteria. He was fitted to this criteria. He was treated with psychotherapy and antidepressant, and he was asked to be in their clinic, and the psychology team has talked to his relatives, as they have not come to visit him. They called and asked for a family conference. So we hope he will be cured in the future. These are my differences. Thank you. Anything you want to ask? The take-home message is all are not saying that go to church. So we have to have a broad mind to identify the problems in the patient. That's as a primary care physician, that's what I have learned from this lesson. So my dear teachers and friends, if you have any questions, you can ask. Hello. Hello.
Fainaz, we can hear.
We can hear you.
Yes. Do you have any questions to ask from me? Madam, are you all there with me?
Yes, Fainaz. It was a good presentation. Your flow was good and how you approached the problem was good. And probably I think it was an eye-opener for everybody just to think beyond, even though with positive physical signs. And I'm very convincing. I mean, the neurological team had been convinced that it is true, but still it has not really been so. So at primary care, I mean, this type of presentations, I mean, are not uncommon. So always to think broad and to have, I mean, psychological or psychosocial issues affecting, I mean, presenting as physical problems always that, I mean, we have to keep in mind. So this is a good lesson, I think, for everybody. I mean, good learning point. Very good, Fainaz.
Thank you. And I must thank my friends and Madam Lalanta, Madam, who helped me to prepare my presentation. and my friends, Sandamali and Dr. Chamita, who helped me to do this presentation with success. Thank you very much, Madam and my dear friends.
Yes, Fainaz.
Madam.
How you understood, the way you have to present things, like not like amnesia. The way you saw the case should not be the way you have, you want to present. So that's the approach you should follow. That's what actually I wanted to highlight is. So you have to give this pay and this, what are the differentials, like the way at the very first time we see patients at the primary care. So this is how you have to explore. So that's why I actually, I want the others of the train you all how to explore things. So I think it's good for the others as well to sort of get the understanding how to present a case. I mean, the same way we did earlier as well, but this particular case, of course, actually I wanted to ask the Fainaz to present in this way. It's very good and very, I think it's very productive one actually at the end.
Thank you.
Fainaz, just to clarify one thing.
Yeah.
Have you any idea about FAST? I mean, in neurology, they use FAST, FAST, FAST.
Yeah. As
can you elaborate about that?
The patient actually they will come to us. So there is be fast. There is we have to look for the B for balance, E for eye movements, F for facial weaknesses, A for I think ataxia, and S for speech abnormality, T for
T for time.
Sorry?
T for time to call. Yeah. Time to call.
Yeah. Time. Yeah. Because as primary care physicians, if the patient comes to us, we have to take a quick history, and if the patient is in the window period of thrombolysis, we have to send the patient for secondary or tertiary care very as quickly as possible. At the same time, we have to think of these functional causes, and at least we can mention it in the BHD or transfer form that they will consider the things, because they are in very busy schedule, very busy setup, so they might not have think of dysfunctional causes. So, as primary care physician, it's our responsibility to find them out and help them in their further management. Hello? Anyone have any clarifications?
Dr. Fainaz, Session here. I have a question.
Yes, patient.
Whether we have a mechanism of outreach to pick up patients like this who are living alone and who don't have any social support, or in an emergency, no sort of reliable way of reaching the healthcare team. Now, this patient, for example, has been in the society alone for a while, without being picked up by anyone. Do our psychiatry services have a mechanism of sort of outreaching and screening this sort of people, which could have probably prevented the thrombolysis, which could have even ended up in an adverse event of bleeding?
Yeah, but Asian, this even though he has not no thrombosis inside the vessels, this won't cause any bleeding. The studies has find out that the patient actually it's a waste of money and waste of resources, but the patient won't get any adverse effect by giving this RTPA to a normal patient. But we have to find out the patient with the socially isolated patient, and we have to give a good service to them as primary care physician. Even the psychology, it's not a responsibility of them. I think it's all of our responsibility to find out them. I think as in Sri Lanka, the GP setup or like thing is established, everyone will be registered to a particular GP, and they will find out the problem in this area. Don't you think, Ishan? I don't know whether psychiatric people have this sort of program to identify.
Yes, I couldn't have agreed more with you. If he had a regular GP, family doctor, he would have probably seen this in advance and sent him to psychiatry services. Thing is, there may be people more like this at the moment. How do we reach out and get to them?
Actually, the psychiatry team goes to the home like this, but the patients who are registered with them.
Yeah, if the patients are not registered, now how
They are
can
not.
we find it? Then we have to have form a new regulation or anything. All should be registered to one particular clinic or any GP or any medical officials. Then they can find out the isolated people and give proper care for them. What do you say, Yeshan?
Yes, I think that is, I agree with you. If he had a regular family physician, he would have probably seen this coming.
So it's up to higher officials should have do this, then we can help them. Right. What else? Any other suggestions? Hello?
Yes, why not?
Yeah. Then thank you so much for your patient listening. Shall we wind up? Madam, thank you so much.
Yeah, Fainaz. Okay, now it's a very nice presentation. Actually, I went through. I mean, like we did everything. But anyway, because I am actually helping all of you all to present like presentations like this. So anyway, now you all know that this should be the way you have to present, and it's very easy for you all to understand and how to work your brain. And anyway, I'm there to you, your junior batch. When you present all the things, I'm there to support you all, right? For everyone. And one more thing. And from next January onwards, on Sundays, actually, I told yesterday on Sundays, I will be there to, I mean, actually once a month to train you all on SCQs, MCQs, and as well as long cases. On Sundays, I'll be doing, or not just once a month. And we were, for the OSCEs, of course, Dr. Malkanti told she will also join for you all to train. Okay? Right.
Thank you, ma'am.
Well understood.
You, madam.
Okay, then we'll be with you all. Okay,
Thank
good night.
Thank you.
you.
Thank you,
madam.
madam. Good night, madam.
Thank you.
Thank you,
Thank you, madam.
Fainaz.
Thank you.
Thank you, madam. Thank you.